the Asia and Pacific region of the League of Red Cross and Red Crescent Societies. Within its borders are to be found the results of both man-made and natural disasters. We are going to take just 3 subjects: relief, disaster preparedness, and development programs, and see how individual societies working in harmony with their own governments and the Red Cross help their respective communities to a better quality of life. Refugees are to be found throughout the region, for example, the boat people of Malaysia. But the highest numbers are now concentrated in Pakistan as a result of the Afghan conflict. Since 1979, over 3 million Afghan refugees have crossed the border down tracks like these, fleeing conflict and seeking shelter in Pakistan. The guerrilla fighters of the Mujahideen, opposed to the current political situation, have gained extensive coverage in the media. But others cross over for family or medical reasons, or simply to escape the latest outbreak of fighting. Initially, the need for the Red Cross in responding to a request from the Pakistan government through the Pakistan Red Crescent Society was to distribute clothing and shoes to those in need. The situation, though, has changed. Now the refugees are coming not just a few miles across the border, but from hundreds of miles away in the interior of the country. They arrive with virtually nothing, and because of the arduous journey, have picked up many diseases en route. The northwest frontier province, where they all arrive, is full to overflowing, and the Pakistan government generously donated land in the Punjab province beside the river Indus. Here 2 camps at Kot Chandana and Daratang were established. The medical facilities at nearby Kalabagh became heavily overstretched, and the League was requested to assist. As a result, the Red Cross concentrated on the renovation of the civil hospital to help the 50,000 refugees who were transferred from the northwest frontier province, and also to serve the local needy Pakistani population. Headed by an expatriate doctor, the League team consists of an administrative surgeon, a general practitioner, nurses and lab technician, local doctors and nurses, an administrator, and engineers recruited through the Punjab branch of the Pakistan Red Crescent Society, plus locally hired drivers, cooks, sweepers, nurse helpers, and chowkidars, the watchmen. Emergency cases from the camp are now only minutes away by UNHCR ambulance. Previously, they had to travel over 50 kilometers to Mianwali. Chief Nurse Denise Leclerc is a French-Canadian seconded by the Swiss Red Cross. A trained midwife, she had to turn her hand to all sorts of jobs, including, for a period, paying the wages of local staff. The patients practice purdah and wear the burqa or total veil. For a week before Pashto and Darzi-speaking nurses arrived, consultations consisted of patients describing their symptoms to a relative who came out of the room to the male chief security officer, who then translated for the doctor. There was only a male nurse in Izzat Bibi's home village of Bani Afghan, about 160 kilometers from Kalabagh. So, with her mother-in-law, she came all the way for examination by a woman doctor. She arrived in time, but many patients postponed treatment to the last possible minute, sometimes too late. The hospital has presently 60 beds, split between male, female, and surgical wards. Pakistani doctor Mohammad Rafiq trained in Lahore and in Ghent, Belgium. Previously, he worked with refugees in Balochistan and was attracted to Kalabagh by the excellent facilities. The laboratory is run by American Roy Dexter, who served previously with the ICRC in Southeast Asia, and by 2 assistants. They handle a wide range of tests and also service the X-ray room, explaining what is happening to attendant relatives. Here, Dr. Rafiq is examining an Afghan with suspected kidney stones. The well-equipped operating theatre is the domain of Janus Kedwis, who has worked as a surgeon with the ICRC in Peshawar, and nurse Hildegard Wolfs, who has served with the League in Somalia, both seconded by the German Red Cross. The medical coordinator, Dr. Claude de Touignan, acts as anesthetist, and with 140,000 potential patients in the town and camp, the teams are kept fully stretched. Without this intestinal operation, the patient would almost certainly have died within 24 hours. This local Pakistani girl has osteomyelitis and needs a plaster cast to immobilize her limbs. An Afghan nurse rehydrates a Pakistani baby with an ORS, oral rehydration salts solution. There are future plans to open a separate pediatric ward. Dr. de Touignan does his rounds with Pakistani colleagues. Every conceivable ailment comes to the hospital, though intestinal and respiratory problems predominate. The creamy pajamas, by the way, were made by the expatriate staff. Denise Lacaire chairs regular meetings of Afghan and Pakistani nurses, a number of whom are Christian, and of nurses' helpers, a job for which there is intense local competition. Links with the townspeople are essential too. Without the quartermaster, Mama, or Uncle Ghulam Khan, the substantial renovation work would never have been finished on time. And Mumtaz Hussain, the chief security officer, is in reality the factotum, the Mr. Fix-It of the hospital. The generosity of the host country and the local communities ensure that costs are kept to an absolute minimum. Even so, the Red Cross budget for refugees in Pakistan has still averaged between 7 and 10 million Swiss francs per annum. Such funds and those for refugees in the rest of the region will continue to be needed for the years to come, and continued financial support is essential if the Red Cross work is to be sustained.
From a man-made disaster to the natural ones that afflicts the region at the rate of almost one a month. The whole area is subjected to the natural catastrophes of earthquakes, floods, volcanic eruptions, tornadoes, typhoons and cyclones. Let's take Bangladesh, which has a large population and is one of the poorest of the poor countries. Annually, cyclones devastate the area, bringing wind and flood damage too. The irony of the situation is that typhoons and cyclones are a necessary evil because they bring much needed water for rice cultivation, the staple food of the population. In their wake too, come floods and build-up of silt at the river mouths, which is rich and fertile, providing much needed additional land and abundant crops. The need, therefore, is to try and minimize loss of life and property by providing adequate protection. After a detailed evaluation, the League suggested a three-faceted disaster preparedness plan too. Number 1, construct cyclone shelters that can resist high-speed winds and ensure that any tidal waves or floodwaters are unable to penetrate. In addition, the cyclone shelters would have a secondary function to be used as community shelters in non-disaster times, where principals and Red Cross basic training in public health care and income-generating projects can be undertaken. Number 2, institute an early warning radio network, equipping Red Cross unit managers with a radio to hear of impending disasters and enabling them then to go out into their individual villages and, with the use of the loudhailer, warn the community to take shelter. Number 3, initiate practice sessions with the villagers and Red Cross officers to demonstrate through actual test sessions what to do and where to go when a real disaster hits. With the resources available, the Red Cross have made a start on this massive project, which will take over 5 to 6 years to complete and will cost some 70 million Swiss francs to finance. Determining that construction must be made in the highest risk zones, an encouraging start has been made, with the completion of 29 cyclone shelters, thanks to the whole Red Cross community, but particularly to the British, German and Japanese Red Cross societies. In addition, the Swiss Red Cross has built 150 houses at Hatia, and 150 families have been rehabilitated and are occupying the houses. The training facet has also started with contribution from the American and the Canadian Red Cross. Just one example of the many pioneering projects initiated by the Red Cross in the whole Asia and Pacific region. Ambitious? Yes. Long-term? Yes. But with the participation of other organizations, Red Cross will continue to strive to bring relief from these terrible natural disasters.
The problems that face both refugees and the indigenous population wherever they settle is very obvious to see. Preventing such human misery and upheaval is a task to which the Red Cross is continually applying itself. Nepal has a relatively young Red Cross Society, which was only set up in 1963. Yet, already there are Red Cross services of some sort in all 75 of its districts. Here it is that a series of innovative development projects are already underway to bring better basic conditions to the population as a whole. A survey of the whole Asia and Pacific area showed that more than 50% of diseases are waterborne, particularly skin and intestinal diseases. In Nepal itself, one of the main long-term problems is clean drinking water. Probably less than 20% of the population has access to non-polluted water. With assistance from the Japanese Red Cross Society, the Nepalese Red Cross has undertaken a vast integrated rural development campaign. One of the aims is to supply clean water installations. By the end of June 1987, 1,500 installations will have been completed, so providing safe water for some 350,000 people. Different systems are used. Here, the Tarai Plain manual pumps draw water from a minimum depth of 15 meters. Beyond this depth, clean water is available. The pump is made in Nepal. This cuts costs and ensures that spare parts can be found in the local market. Whenever possible, and especially in the hillside regions, the gravity feed system is used. This consists of channeling clean water from the heights down to the village, using cheap local materials easily available, bamboo. The construction of a pump or a fountain is a first step in this integrated rural development program. It is always followed by a basic health program and rural development. In order to promote these programs, health committees are set up in each village. 1,500 village health workers have been trained by the Red Cross throughout the country. First aid, oral rehydration, and basic hygiene are all being taught. The workers then share their knowledge with the villagers in their community. This is a public demonstration of the preparation of an oral rehydration solution. Hira Bahadur Gurung is one of these village health workers. He is very pleased with the progress made in his village of Kirtipur. Not only will the program enable the inhabitants to improve their environment and lifestyle, but it will also help develop community feeling among the migrants from different regions. The construction of latrines is strongly encouraged by the Red Cross, which covers part of the construction costs. Each village health worker makes it his duty to encourage such installations and their use, thus avoiding the spread of communicable diseases. Many other integrated rural development projects exist across the country in Jumla district, Panoti, Nala and Khairmara. In Panoti, a project has been carried out with Swiss Red Cross assistance since 1983. Preventive medicine, sanitary education, the plantation and maintenance of 20,000 trees, plus protected furnaces which allow up to 50% in fuel economy are, with the construction of a drinking water canal, the principal components. In Nala, a similar project is being carried out with assistance from the Australian Red Cross Society. Great importance is given to community participation via numerous information sessions and the training of women. A nutritional survey has been established for children under the age of 5. Deficiencies are compensated for by the distribution of foodstuffs with high protein content. In Khairmara, a group of villages near Janakpur in the south of the country, life is very hard. A severe iodine deficiency has caused many cases of goiter among the population. Cretinism is also prevalent. In the village of Bailhas, there are sadly 30 such cases. The nearest dispensary is 25 kilometers away on foot. The only way some patients are able to see a doctor once a year is through the mobile clinics organized by the Red Cross. This woman is suffering from tuberculosis and would soon die without adequate medical attention. In order to tackle the most urgent needs, the Red Cross has organized, in cooperation with the government, a vaccination campaign and iodine injections for all women able to have children. Assistance is also given to the most needy through handicraft training. This enables them to generate some income. Each day, the school children receive highly nutritious breakfasts. Pregnant and lactating mothers, as well as families with under 5-year-olds or abnormal children, receive food aid. It all goes to show that a small Red Cross society can do a great deal with enthusiasm despite limited means. 3 examples that are symptomatic of the needs of the Asia and Pacific region as a whole. Disaster preparedness programs from the scourges of the endemic natural catastrophes that predictably occur every month. Relief for the victims of the ravages of war and man-made conflicts, the refugees. And the development programs that in years to come will help alleviate the problems of the people of the entire area. These are not just one-off situations, and continuing financial support will be needed for the Red Cross to fulfill its role in bringing a better quality of life for all the peoples of the Asia and Pacific region.